Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. In Nigeria, about 150,000 babies are born every year with sickle cell disorder, many of whom do not make it to their 5th birthday. Sickle cell disorder is an inherited disease where blood cells are abnormally formed. Instead of a biconcave, malleable structure, they assume a sickle-shaped, rigid structure which cannot hold much oxygen and has the tendency to block small blood vessels. There may be problems with anemia, pain, infections, leg ulcers, stroke, and a host of others, which are managed by prevention or treating the particular problem. A more permanent solution, the bone marrow transplant, is gaining more attention now. My guest is a doctor in internal medicine at the Lagos State University Teaching Hospital, former head of clinical services, Sickle Cell Foundation, and he still volunteers at the Sickle Cell Foundation. You're welcome to the show, Dr. Ajibola Sanda.
Thank you for having me. Good afternoon.
I've often wondered, why do they have infections? What's causing an infection?
So just like you earlier explained, sickle cell disorder has to do with the abnormal red blood cells. There are different cells we have in the blood, but for sickle cell disorder, what is focused on is the red blood cells. And, the patients are in we call it a catabolic state. So their bodies are always trying to regenerate more red cells. Thereby,
because of the ones that
are abnormal,
misshapen.
So they die early. So because they are abnormal, they have a whole lot of problems. They die early. They have inability to carry enough oxygen and nutrients. So the child is most times in a deficient state.
That's true, nutrients too.
And all this can lead to different complications, infections being one of them. So they are unable to fight some organisms, which some organs in the body, like the spleen, for instance, is meant to help them fight. We call them encapsulated organisms. So because the spleen in children with sickle cell dies at a very early age, so the medical term is auto-infarction. So they are at risk of myriad of infections.
Okay, so what happens is they can't fight an infection.
They can't fight most infections adequately.
I see.
Yes.
That makes a lot of sense. Okay, so we're talking about the bone marrow transplant. Obviously, we've heard about that, and it's used now to cure.
Yes,
isn't that wonderful? But who qualifies for a bone marrow transplant?
So a bone marrow transplant is a procedure done for patients who have sickle cell to, let's use the word, cure them of sickle cell disorder. But it's not just for sickle cell alone. A whole lot of other conditions can benefit from, leukemias, some other blood disorders, some lymphomas. They can also benefit from a bone marrow transplant. But does every patient with sickle cell require a bone marrow transplant?
That's the question.
The answer is no. Because sickle cell on its own is not a death sentence. In fact, currently the average lifespan of sickle cell is about 63 years old. So the inclusion...
That's even more than the lifespan
of the average
Nigerian.
Exactly. So the inclusion criteria for those who qualify for a bone marrow transplant are those who have repeated recurrent vaso-occlusive crises, those who have had different complications from sickle cell disorder, such as a stroke, an acute chest syndrome, repeated VOCs.
What's VOC?
Vaso-occlusive crisis, which takes them to the hospital regularly.
That's where the vessel gets blocked.
Exactly, causing them pains and all of that things. So those are the kind of people that we recruit to have a bone marrow transplant.
So if it's mild, you tell them no. Let's handle this some other way.
Yes, because it is treatable. It's a chronic condition that you can actually manage.
Okay.
Yes, just like the hypertension and the diabetes.
All right. So in a bone marrow transplant process, we see this huge needle going into the hip of somebody. Who is that person? Is that person the patient or the donor? So
the procedure, let me just briefly describe the procedure. Most people think it's a surgery. It's actually not a surgery, so to speak. It's more like a blood transfusion. So what happens is bone marrow transplant is done between two immunologically compatible donors.
Okay.
So before you can donate a bone marrow to another person, they would have done a couple of tests. We call that the HLA test, the human leukocyte antigen, which shows that the person donating to the patient is a perfect match. In some cases, you can do what we call a half-match bone marrow transplant, but you still do the test. You find out that, okay, these two people are a match. And most times we use related donors. So you use siblings, You use sometimes parents, and sometimes you can also use unrelated donors who match the person.
Unrelated donors?
Yes.
No, this is a first for me.
Oh, okay.
I haven't heard about this
yes.
before.
So there's an unrelated matched donor. You get a person's HLA and you put it in you put it in a donor registry, and you might find another person unrelated who matches that person's profile. So
it's not just a case of matching AA or AA blood or positive
it's a lot more
negative
complex.
blood.
It's a lot more complex than that. The matching process is a lot more complex than that. But you find that most times siblings are the ones who donate for other siblings. So you harvest the bone marrow from the donor. Now there are different ways.
Through the
so there are different ways.
Or through the hip.
There are different ways. You can harvest through the peripheral blood, like when you're collecting normal blood.
A normal blood transfusion.
Yes, but you would have primed that person, giving him some things, we call them GCSF, so granulocyte colony stimulating factor.
Okay.
They would help the patient generate what I don't want to use technical terms.
Okay.
But in the peripheral blood, we'll be able to get the cells we need.
That you actually need for the transplant.
Yes, but the best site of donor is actually from the bone, because you can get because you can go directly into the bone marrow and get enough cells.
Is that why you go to the bone marrow?
Yes, that's
not because the blood you need is only in the bone marrow.
No. You can get it from the bone marrow. You can get it from the peripheral blood. You can get it from cord blood. That's from placenta.
From placenta.
When a child is born, and sometimes even from fetal liver. Even from the liver, you can also get it from there. So there are different sites.
Better. This gets better as
we
go along.
But the best yield is from the bone. It's from the bone marrow itself.
So is it the whole blood you put into you transfuse into the patient?
So once you get your bone marrow, you take what you've gotten from your recipient.
So you have to fractionate it
back to the lab, yes, and you collect the cells you need, because you have a lot of fragments and other things you don't need. So you take what you need. And maybe I should say this, that the process of collecting your blood from your patient, the other patient is put under general anesthesia, so they don't feel any pain.
Okay.
They don't feel, in fact, when they wake up, they don't even know anything has happened. Maybe just paracetamol. Great. Yeah, it's a very painless procedure.
Okay.
And then the blood you've gotten from that patient, you would now transfuse into your donor. But a lot of things happen before you transfuse the bone marrow you've collected into your donor. You would have to give the person some drugs, we call them conditioning regimen, that would suppress the person's own immune cells.
I hope this isn't too overwhelming for a patient.
It can be, especially the conditioning part for the recipient, so because you are reducing his immunity.
So everywhere has got to be sterile.
Sterile. So at that point, he can be predisposed to minor infections, but you keep them in a sterile room that has one airflow of oxygen. So the oxygen inflow into the room is just one way. They have their own separate toilets. They have their own separate food. They are not exposed to everybody. Anybody going into the room has to have a sterile.
So they are sort of like in an isolation center.
They are sort of like in a sterile box. They are not isolated.
All right. So you've transfused this blood now into this new patient. Does he now begin to make it for himself?
So what now happens is, yes. So the blood goes into the marrow and sort of switches the functioning of the marrow to start producing what it was given. So
it's difficult to wrap my mind around that. So somebody starts to produce another blood entirely that is not his own.
Yes.
Okay. I want to go to, carry on.
I would like to mention that, but after the transplant, the patient's genes do not change.
So he's still SS in his gene, but he's AS or AA in his blood.
So
all right. A lot of times, some sickle cell patients they just suddenly have leg ulcers.
Okay.
After this procedure, does it mean no more leg ulcers?
So after this procedure, they don't have any sequelae of sickle cell disorder.
No leg ulcers?
No, they are not meant to have leg ulcers. They should not have strokes, no priapism.
No chest syndrome?
No pain, no, none of that.
No sickness?
No, none of that.
Not disposed to infection anymore?
No. They become whatever genotype they were given before that time.
It's like magic.
Yes, so it's either they become AS if that's what the donor was, or they become AA if that's what the donor was.
And if you do it early enough, does that mean that the patient can grow normally?
So it is actually advised that bone marrow transplants are done in younger age groups.
Okay.
So when you do it in people between the ages of 2 and 15, you have less risk of complications. you have less risk of graft versus host disease, which is the major complication you have from bone marrow transplant.
That's just like a normal rejection of,
yes, a rejection
transplanted
process, which is what you are trying to avoid. So we advise that it is done in younger children who have qualified for the need. So maybe from about the ages of 3 till about 15. It can be done even after that, but you know, with that comes more complications, more drugs you need to give for the conditioning, and so on.
Okay, so if somebody wants to go in for this transplant, how long does the person stay in the hospital, start to finish?
So let's say give or take 12 weeks.
12 weeks.
12 weeks. Because you want to monitor the patient. First of all, you want to admit the patient. You want to run a couple of tests while the patient is on your admission. You also want to harvest the bone marrow from the recipient. And then while you're harvesting the bone marrow, you start conditioning your donor with your chemotherapeutic drugs. And that patient is in the isolation room before you now transfuse your patient with the blood you got from your recipient. And even after you transfuse, you have to monitor the patient closely. You know, so it's something that you run some blood tests, sometimes 3 times a day, and as the weeks go by, the need for the blood test starts reducing. So you don't want to release the person into the general community almost immediately, because the person still needs isolation, the immunity is still low. You want to see that the graft has taken, and you want to be sure before you
But you can release your donor.
Oh, the donor
after
goes
the first day.
Immediately after the first day, yes.
So do you empty the body of blood
from the donor?
From the recipient before you replace?
No. So you don't. So you give drugs that will reduce the immunity. You sort of reduce the functionality of the bone marrow of the recipient, such that his body will not, his white cells will not fight against the new cells that are coming in. So that's what the drugs are for, and that's why you keep them in the sterile room. So for people who are sickle cell, there are 2 types of conditioning regimen: the myeloablative and the non-myeloablative. But for people who are sickle cell, we generally give them the milder course of conditioning regimen, because we don't need to suppress the bone marrow completely.
Okay.
So we just suppress it to a certain level with certain drugs, and you know that improves the outcome. Unlike if it was for a leukemia, where you have to suppress the bone marrow to 0.
Wow.
Yes.
Okay, so this is a lot better.
So this is a lot better. So for conditions like sickle cell, the bone marrow transplant, the outcome is usually better, because you don't...
Talking about the outcome,
what
would you say is the percentage of success of these transplants? So at least, the Sickle Cell Foundation has had like 50 people go to Rome for the process. So what's the
bone marrow
success?
Transplant is a complex procedure, which is the reason why, first of all, you don't offer it to every patient with sickle cell disorder. Those who are doing well on their regular routine medication, you don't want to put them through extra stress of a bone marrow transplant. Talking about the success we've recorded so far with the 50 patients we sent to Rome, we had about 75% to 80% success rate, which is very good for any transplant program. Very good.
For those ones that are not exactly successful, can they just go back to the old method of prevention and management?
So some of them we lost some. Some of them the transplant did not take. So yes, they will just revert back to
the old method, so they're safe.
Yes, and we treat them with that.
So what's the recovery period like? What I mean is, you'll answer this after the break, but can they walk, can they eat normally and everything after the transplant while they're still in hospital? But we'll do that after break. Please stay with us, and we'll be back in less than no time. Welcome back. The number to call is 0808-054-2233 if you have questions about sickle cell disorder, and you can also tweet at CTV_Mary A. Now we are talking about the recovery period. Can this person eat, walk around after the procedure while they're still, within the center?
Their children, you cannot stop a child from running
Except
and playing.
the pain is too much.
Exactly.
If it's too much.
But most times after the procedure, a couple of days, you find that the child is already active, already mobile, moving all up and down the hospital. Their mothers are always with them. So it's an amazing... In fact, your hospital has to be child-friendly.
Okay.
Yes, so you see them walking all around the transplant suites, enjoying themselves almost immediately after the procedure.
Okay, I have Taiwo on Twitter asking, is there any possible complication after the transplant? And I hope it does not, it is not very expensive. So talk about that, you know, and in conjunction with how prepared we are now in Nigeria to offer this service.
So yes, the transplant, like I explained, is a complex procedure and it can have complications like every other procedure. But sometimes the complications can become very severe. So the major ones we have are the graft versus host disease, which can affect almost every system in the body, from the skin to the GI tract to the liver to the heart. You know, yes, so you can have complications from this procedure.
Let me quickly take Victor from Sapele. Hello, Victor.
Hello, good afternoon, ma'am.
What's your question, Victor?
Okay, my question is, they are talking about...
Please, could you speak up a little bit?
They are talking about this bone marrow transfer.
Right.
I want to know where it could be found.
Where they took it from? Okay, perhaps you didn't tune in.
So where it could be done?
Where it could be done. Okay, okay. So go ahead with that.
So,
thank you very much.
Yeah, so Sickle Cell Foundation Nigeria, in conjunction with the Lagos University Teaching Hospital, LUT, put up a transplant unit, and it should kick off by October of 2019, which is a few months from now.
Okay, that's
yes.
really good, and we are very happy.
Yeah, we're very happy.
But why do we
that.
have to wait till October?
Putting up, we want to put up a standard world-class facility, and you know things can take time, especially the funding. Okay. So we have already trained personnel for the facility. All we are doing currently now is equipping the facility and putting everything in place for our patients that are coming in, or our clients. You know, they are not there. We don't want to call them patients. And so by October 2019, it will be available in Lagos. It will be affordable for our people.
Okay, we'll talk about the money in a minute, but let's take Tunde from Lagos. Hello, Tunde.
Hello, good evening.
You're welcome to the show. What's your question?
I want to ask, what's the survival rate after having the... Huh?
Go ahead.
The survival rate, that's one. Then two, what actually happens, or what's the efficacy of the chemo and the transplant?
Okay.
I mean, which one is actually better, or, I mean...
Okay. Okay, thank you. We'll let the doctor answer that. Oh, you've already talked about the success rate being up to 85?
The ones we have done with
the ones
Rome.
You did?
Yes, the ones we've done
with Rome. So he's
Rome.
talking about chemo versus...
So maybe he didn't understand what I
exactly.
meant. So the chemotherapy is for the conditioning.
It's part of the bone marrow transplant process.
Yes, it is to suppress the marrow of your recipient before transplant. So it is not either chemotherapy or bone marrow transplant. It's all a process together.
But how about radiation? Does that take place?
Not every time. There are specific indications where we would need to radiate some cells that we will need to give to the patients in specific conditions. You know, so yeah, but it's not routine. But sometimes when you need to give them blood or some other things, you need to irradiate those blood cells.
Okay, so let's talk about the cost quickly because people are concerned.
Okay.
From what I read, somebody was saying the procedure coupled with travel, stay abroad and everything, it could come to as high as 25 million naira.
So in
but coming back to Lagos, how much do you think we can cut off that?
So it's not 25 million naira outside. If you go to India, you put the cost together, it's almost about 35, 40 million.
Wow.
In the US, it's about 150 million. In the UK, about 100 million. But we are looking at putting the procedure at under 10 million naira. So let's say between 5 and 10 million naira. An actual figure will be put to it, but it's going to be more than 75% reduction in what is available anywhere else in the world, coupled with the fact that you don't have to travel, so there is no travel cost. You are going to be in Lagos. I'm sure everybody has a relative in Lagos, so you don't need to rent a hotel.
Okay. So let me quickly take this from Christopher so he doesn't drop. Hello, Christopher. Christopher, you need to put your TV off. You need to put your TV off so that we can hear you. You need to put your TV off so that we can hear you.
I'm hearing you. Are you not
Okay,
hearing me?
go ahead. Looks like we lost Christopher. So let me quickly go to the other people. Not everybody is going to qualify for a bone marrow transplant. You've talked about prenatal diagnosis. Is it possible after prenatal diagnosis, when you've certified that this person is a sickle cell carrying person, to start intervention immediately?
Yes, so the aim of the prenatal diagnosis is to, first of all, early identification of the genotype of the fetus. So most times you find out that what happens with patients who die from under 5 mortality with sickle cell disease is that their parents were not earlier informed, and methods, actions were not being put in place. So we've done a research, and it has been shown that patients who have been detected early have better outcomes. So they get their vaccinations that they need very early. Treatment is put in place very early. The mother, the health providers are already always on the alert to intervene for that child in case there is a need to. So prenatal diagnosis, early detection of the disease helps in the long-term outcome of the child.
Okay, let's quickly talk to Matthew from Lekki. Hello, Matthew.
Good afternoon.
Good afternoon. What's your question?
All right. It is actually a very nice program you are giving us this afternoon, but I think you should tell your audience what are the causes of this disease. You understand? Also, what leads to this? So that I say no, but the people listening may not know. Most of the people listening may not know. There should be an awareness kind of before we start talking about how to curb this per se.
Okay, thank you, Christopher.
So sickle cell disease, sickle cell disorder is an inherited blood condition where two partners who carry the S gene come together, and with each pregnancy, there is a 25% chance of having a child with the condition.
So if somebody with AS genotype marries another person with AS genotype?
In each pregnancy, there is a 25% chance. That is not 1 in 4 children. So sometimes you can have 4 children, 4 of them will have sickle cell, and you can have 4 children, none of them will have. So it's a game of chance.
Yes, because a lot of people misunderstand
yes.
and think that, oh, I'm going to first have 3 normal children.
Exactly.
The 4th one will be sickle cell, so I will just have 3 children and I'll be fine.
So it doesn't work like that. So in each pregnancy, there is a 25% chance of having a child with SS gene. So it's an inherited condition, and that is how it is gotten.
Okay, so going back to prenatal diagnosis, sickle cell patients have a look. If they've been suffering for a long time, you can see that some people, the hip joint is out of position, they're very thin and have a certain look. If prenatal diagnosis is acted upon as it should be, do they escape all that? And how does that affect cost of care later in life?
So the peripheral stigmata, like you were just mentioning, will I say the complications of the sickle cell disease, sometimes with good care, you might be able to avoid some of them.
Okay.
Yeah, but how the patient will look going forward might not
is anybody's guess.
Yes.
Thank you so much for coming to the show, Dr. Sanda.
Thank you very much for having me.
And thank you very much for staying with us. I hope you all enjoyed it. Sickle cell disorder is the highest burden is in Nigeria, so we better take notes. Have a wonderful day.